If there's one place where speed and precision are literally life or death, it's got to be the emergency room. Picture this with me. A 62-year-old man, he's barely breathing, clutching his chest, seems confused, struggling. Every single second that ticks by is a critical decision point for the team there. Our deep dive today is pulled directly from a real clinical case study, just like his situation. We're going to unpack a condition known as a massive pulmonary embolism. That's a really critical moment where a blood clot blocks a major artery in the lungs. So our mission here is to understand precisely what makes a PE massive, why it's just so profoundly dangerous, and maybe most importantly, the exact life-saving steps required when a patient faces this kind of acute crisis. We'll look at the critical decision that differentiates survival from much worse outcomes.
It really is an incredibly high-stakes scenario. And in the case we're looking at, our patient is a 62-year-old male. He came into the ER with a pretty significant medical history, things like hypertension, coronary artery disease. But here's the really crucial detail, the one that immediately raises a red flag. He'd recently had hip replacement surgery. And that specific procedure, well, it's a very well-known risk factor for developing blood clots. Deep vein thrombosis, or DVT, which can then travel to the lungs.
Right, so he's got these underlying conditions, these predispositions, and then the surgery. So he arrives at the emergency department. What did his presentation actually look like? I mean, what were the symptoms just screaming emergency to the medical team?
Oh, his presentation was definitely alarming. He came in with acute pleuritic chest pain, that sharp stabbing pain that often gets worse when you take a deep breath. He also had severe dyspnea, which just means difficulty breathing, and he was feeling dizzy. His vital signs were, frankly, screaming crisis, very low blood pressure, 80 over 60 millimeters of mercury, a rapid heart rate, 120 beats per minute, and fast, shallow breathing at 24 breaths per minute. On top of that, he was mildly confused, and his oxygen saturation, dangerously low, 88% just on room air. All those signs together, they just paint this picture of a system in really severe distress.
Wow. Okay, with vital signs like that, screaming crisis, as you said, how quickly can doctors actually pinpoint something like this? What was the definitive diagnosis here? How did they confirm it?
Yeah, speed is critical. And that's where the CT pulmonary angiogram, or CTPA, comes in. It was the definitive diagnostic tool for this patient. It confirmed a massive pulmonary embolism located in his right main pulmonary artery. But the critical finding wasn't just the clot itself, although that's obviously huge. It was that he was clinically in shock and showed clear signs of right heart strain. That combination absolutely underscores the severity.
Okay, you mentioned massive PE and right heart strain. Now, we hear about blood clots, PEs, quite often. But what exactly elevates a pulmonary embolism to this category of massive? Is it simply about the size of the clot, or is there something more going on?
That's a really great question, and it's absolutely key to understanding this. It's not just about the physical size of the clot, although, yes, large clots are typically involved. What truly defines a massive PE in clinical terms is when it causes hemodynamic instability. Basically, this means the patient is in cardiogenic shock or experiencing severe hypotension. Their circulatory system is failing to adequately perfuse the organs. Just like our patient was, it's like a full-body crash, really, not just a localized blockage in the lungs.
I see. And so this right heart strain you mentioned earlier, why is that particular sign such a critical indicator when a patient is in this state? What's it telling the doctors?
It's absolutely vital information because it tells us that the heart's right ventricle is struggling, like immensely. See, this part of your heart, the right side, its job is to pump blood into the lungs to get oxygenated. Now, if that pathway, the pulmonary artery, is obstructed by a massive clot, the right ventricle has to work against this enormous pressure. It gets stretched out, it starts to fail, and it just can't deliver enough blood forward to the left side of the heart and then out to the rest of the body. So the common signs we look for and exactly what our patient showed are things like tachycardia, fast heart rate, hypotension, low blood pressure, and altered mental status, the confusion. They all point to the heart really struggling under that immense strain.
Okay, that makes sense. Now, given that every second counts and maybe a patient is too unstable to even move for a full CT scan right away, are there faster sort of bedside tools clinicians can use to get a rapid assessment of this right heart strain?
Precisely. Yeah, absolutely. That's where tools like POCUS, that's point of care ultrasound, become just invaluable. They allow clinicians to quickly look for signs of right heart strain, like a dilated right ventricle, and also IVZ, or inferior vena cava distension. Basically seeing if the big vein returning blood to the heart is backed up. They can do this right there at the bedside.
Yeah.
It gives them crucial information about the heart's function and the patient's fluid status, when maybe moving them to radiology for that definitive CT scan is just too risky at that moment.
Got it. So Okay, let's bring it back to our patient. We have a confirmed massive PE. He's in shock, showing clear signs of right heart strain. This is truly the moment of truth, isn't it, in the ER? If you're the doctor standing there, what is the first, the most appropriate, the life-saving step in this really dire situation?
Right. So for a patient in this critical state with a massive KE that's causing this hemodynamic instability, the most appropriate and crucially the immediate next step is fibrinolytic therapy. We're talking about drugs like TPA or Alteplase. These are the absolute first-line treatment in this specific acute emergency, no question.
Fibrinolytic therapy. Okay, it sounds
Yeah.
powerful. Can you explain for our listener what exactly is it doing inside the body that makes it so uniquely effective right here, right now, compared to other treatments we might hear about for clots?
Yeah, what's really fascinating is its direct action. The primary goal, the whole point of fibrinolytic therapy is to rapidly dissolve that thrombus, that big blood clot that's blocking the pulmonary artery. By literally breaking down the clot, it drastically reduces the pressure building up in the pulmonary artery, and most importantly, it helps restore stable blood flow through the lungs and to the rest of the body. These are often called clot busters for a reason. They're designed to immediately reverse that life-threatening obstruction.
Okay, immediate high-impact result. But I imagine that kind of power, that clot-busting ability, probably comes with significant risks too, right? What does the immediate follow-up care look like once that therapy is started?
You're absolutely right. It's definitely a high-stakes treatment for a very high-stakes problem. There are risks. These patients require admission to an intensive care unit, an ICU, for very close monitoring. The main concern is the significant risk of bleeding complications from the therapy itself. Plus, you're still dealing with the patient's underlying cardiovascular instability. So they need constant vigilant observation by a specialized team, checking neurological status, watching for any signs of bleeding, monitoring hemodynamics continuously.
Right, intensive care.
Yeah.
So fibrinolytic therapy is the clear go-to for this massive, unstable PE. But, many people are familiar with other treatments for blood clots. Let's talk through why some of those aren't the first choice here. For instance, intravenous unfractionated heparin. We know heparin is used all the time for clots, so why wouldn't that be enough in this scenario?
That's a really common question, and it's an important distinction. While anticoagulation therapy, like heparin, is absolutely essential for managing pulmonary embolism generally, heparin alone is simply insufficient for a massive PE with shock. Its main role is to prevent new clots from forming and to stop existing clots from getting bigger. But it doesn't actively dissolve or break down a large obstructive clot that's already causing the patient to be hemodynamically unstable, to be in shock. For someone crashing like our patient, the urgency demands immediate thrombus dissolution, breaking up that clot now. And only fibrinolysis can really provide that rapidly. Heparin is critical. It's usually started alongside or right after fibrinolytics, but it's more for lower risk, stable PE management as the primary immediate therapy, not for this kind of acute, life-threatening crisis.
Okay, that makes perfect sense. The speed of action is the key differentiator there. What about oral medications? Things like oral apixaban or rivaroxaban. A lot of people take those pills for various clot-related issues. Why wouldn't we just give this patient a pill?
Another excellent point. Those oral anticoagulants, the DOACs, they are highly effective and much more convenient for long-term use. But they are designed and indicated for stable patients, patients with non-massive PE or for long-term prevention who don't require this kind of urgent, immediate intervention. Our patient here is profoundly unstable, in shock. Giving an oral medication, while it just isn't going to address or fix that immediate life-threatening obstruction quickly enough, it takes time to absorb, to start working. This scenario demands immediate, aggressive intervention that really can only be delivered intravenously to have an effect fast enough to potentially save life.
Right, the immediacy again. Okay, what about surgery? Surgical embolectomy. I mean, that sounds like the most direct approach, right? Go in and physically remove the clot. Why isn't that the first step?
It definitely sounds appealing, doesn't it?
Yeah.
And surgical embolectomy can be a life-saving procedure in certain circumstances. However, it's generally considered a secondary option, not the first line for most cases of massive PE with shock. It's typically reserved for situations where fibrinolysis, the clot buster drug, fails to work, or maybe if the patient has a clear contraindication to getting fibrinolytic therapy, like if they have active bleeding somewhere else, or recent major surgery or trauma. It's not the first choice because, well, it carries higher risks itself. It's major surgery, requires specialized teams, takes longer to initiate, and has potential complications associated with the surgery and anesthesia. Compared to the relatively rapid, less invasive administration of fibrinolytic therapy, surgery is usually held in reserve unless absolutely necessary.
Okay, secondary option, that clarifies it. Finally, one more thing we sometimes hear about, an IVC filter, inferior vena cava filter. How does that fit into this picture, or does it not fit here?
Ugh, the IVC filter. Good question. It's relevant to clots, but not in this acute treatment context. The IVC filter is primarily for secondary prevention of PE. Think of it like a tiny filter or net placed surgically in the inferior vena cava, that's the large vein carrying blood back from the lower body to the heart. Its job is to physically stop new clots, usually from the legs, DVTs, from traveling up into the lungs. It's typically used for patients who, for some reason, can't take anticoagulant medications, maybe due to high bleeding risk, or sometimes for those who experience recurrent clots despite being on anticoagulants. So, crucially, it does not treat the acute massive PE that's already in the lungs. It doesn't reverse the shock, it doesn't dissolve or remove the existing thrombus, and it doesn't restore the pulmonary circulation. It's about preventing future PEs, not fixing the one that's causing the immediate life-threatening crisis right now.
Wow, okay. That's a really detailed look at a truly critical medical moment and the complex decisions involved. So if we try to bring it all together now, what's the single most important core takeaway for our listener from this deep dive into massive pulmonary embolism?
Yeah, if you remember just one thing, it's probably this. When a patient has a massive PE with shock, the clock isn't just ticking, it's racing towards a cliff edge. And in that immediate moment, only one intervention, immediate fibrinolytic therapy, the clot buster really has the power to potentially pull that patient back from the brink. It's sort of the ultimate shock treatment for a circulatory system that's in full collapse. It absolutely demands precision, speed, and then that really intensive follow-up care we talked about.
It really does highlight the incredible precision and the just unbelievably rapid decision-making required in these critical medical scenarios. The profound difference that an accurate diagnosis and making the right immediate intervention can make. Well, it's truly astonishing when you think about it in a life-or-death situation like this. So, but maybe as you reflect on this, here's a final thought. How does understanding the sheer severity and the specific time-sensitive treatment needed for something like a massive PE, how does that deepen your appreciation, maybe, for the body's incredibly intricate systems, and perhaps also for the profound, almost miraculous sometimes, interventions that modern medicine can offer to try and restore balance when those systems are pushed to the absolute extreme? Something to think about.